Here we go.
So, Twain, can I start?
Yes, trying to start this streaming.
Okay.
You still have 1 minute.
Sure. Yeah, you give me the green signal.
So I'll give it to you in a minute. I'm
Okay.
just teasing you. I just want to make sure that we are live streaming for sure. It's still setting up. There we go. Just 1 second. I just want to make sure that there we go. Okay. So now, good evening, everyone. Welcome to Medical Mondays with Dr. O, to another exciting evening of learning. I am excited about tonight's topic because it is something that is hitting home and that I am not actually very happy about. And we have to be very careful about it. Dr. Toyin Okwesomi, and I practice in Maryland, as you all know. Without much ado, though, I'm going to yield to my brother, Dr. Natarajan Ravendhra, who has transitioned to Johns Hopkins as a professor, but I'm going to let him complete his introduction, who is going to talk to us today about this very important topic, fatty liver, as I love to call it. So, Dr. Ravendran, the floor is yours.
Okay. Thank you. Good evening, everyone. And I'm Ravendhran, as Dr. O, introduced me. And I'll tell you, I'm very passionate about liver disease. And I always tell liver is the center of the universe. I'm very biased. I was trained at University of Miami by the legend, Dr. Leon Schiff, who wrote the textbook, So in the past 3 decades, I've been doing, liver diseases. I've been doing a lot of research and educating my colleagues and friends and students and teachers and, fellows. Now, what is currently happening? I think the whole topic, it's called a non-alcoholic fatty liver disease, but I put it in parentheses because that nomenclature has changed. Now, currently we call it as a MASLD. MASLD stands for metabolic dysfunction associated steatotic liver disease. It's such a mouthful. I'll tell you why all these things started. In the past 2 decades, we've been observing patients who come to our office getting in cirrhosis. And, as soon as they hear, oh, you have cirrhosis, the first reaction would be, Doc, I don't drink. How come I get cirrhosis? Then what we found out in the past, almost 2 to 3 decades, the whole cohort of patients who develop fatty liver then go on to have fibrosis and scar in the liver. They got cirrhosis. So we call them as non-alcoholic fatty liver disease. But when a patient walks into your office, as soon as they hear the terminology non-alcohol, that means they immediately feel stigmatized. Oh, our doctor is already thinking, I'm not drinking, I'm drinking alcohol. Then you add on the top fatty. Fatty means, again, they feel so stigmatized. So much so, in the past 3 years, the whole movement, actually, it was patients-driven movement to change the nomenclature. And the whole global community, not belonging to one country, it's a whole global community, made this nomenclature change last year in European Society of Gastroenterology meeting called MASLD. Now, MASLD also makes sense. Why? If I explain, MASL means metabolic dysfunction. Now, diabetes is a metabolic disease. Hypertension is a metabolic disease. These diseases are the one that are driving force in what happens in the liver. So what I thought next to 40 to 45 minutes, I will go over with you the nomenclature and how do you identify these patients and what is the pathogenesis, what is currently going on treatment. I'm going to combine both technical, scientific, and non-technical terminology in such a way that it will be quite explanatory, and I'll make it very fun also. And I'll reserve last 10 to 15 minutes for question and answer session, because I would like to wind up by 8, at the most 10 past 8. Now, I might skip some of the slides because some of the slides are a little bit too much. I don't want to go over the board, as well as it's not necessary. So moving on to the next slide. Oh, here it is. Now, this is what I came up with. This slide looks very busy, but I'll explain to you. Look into the top. It says steatotic liver disease. What is steatosis means? Steatosis means fat in the liver. Fat is very crucial part. As we all know, we derive our energy through three sources: fat, carbohydrate, and protein. Protein is the source of all the hormones and all the carrier proteins and the muscle. It doesn't have much role to play in energy. Fat and carbohydrate are those two sources of energy for the human mechanism, I call it the human machinery to function. If you don't have liver where this fat and carbohydrate is converted into going through almost in the mitochondria, the fat gets broken down into free fatty acids. That free fatty acids, it makes a conversion of ATP to ADP. It actually gives away one phosphatase. And during that process, one electron is utilized. And by oxygen and that electron, that mechanism, it gives you that energy. Just like a nuclear energy we get, that's what happens in human body. And that happens in the liver at the mitochondrial level. That is why some patients who have liver disease, they always complain, I don't have enough energy, I feel fatigued. So fat is normal storage in the liver. But if it goes beyond normal storage, what happens is it almost creates a thermal energy in the liver, which causes damage to the liver cells. When the liver cells gets damaged, it recruits scavenger unit. The scavenger cells or the inflammatory cells, they try to come and remove the scavenger. Almost like, when we have like in the houses, you have scavengers, they come and clean all the dirty things. When the scavenger cells comes and removes it, it starts to leave behind scar tissue. And this process goes on for years and years. And over a period of 20 to 30 years, it becomes cirrhosis. Now, in the liver, the nature has built an inbuilt mechanism for every fat that is made. We also have inbuilt mechanism in the liver that breaks down the fat. There are certain enzymes in the hepatic stellate cell, or it is called Ito cell. That cell produces this enzyme to break down the scar tissue. But unfortunately, if you are putting out too much scar tissue, and if you have a less enzyme breaking down, that's what happens. This is what classically happens in the liver diseases. Every day, there is certain element of inflammation goes on in the liver, certain element of scar tissue puts in, and our liver makes the lysis of the fibrous tissue, and it becomes normal. This is the whole pathogenesis of scarring happening in the liver. So when you have a fat in the liver, what are all the diagnoses or what are all the reasons? So there are 5 reasons, as you see here. Number 1 is called metabolic dysfunction associated steatotic liver disease. I will go over with you the next slide. What does it mean? So it is called MASLD. This is the terminology we used to call it as non-alcoholic fatty liver disease. Now, moving on to the second bullet, which is second point, is MET-ALD. What is MET-ALD? Now, there are some patients who do have MASLD, And on the top of that, they do drink alcohol. So if they drink alcohol and if they have concomitant MASL D, it becomes more scar tissue, more inflammation. The cirrhosis, the duration of cirrhosis is so shortened. It's not quite a linear. It becomes almost like a longitudinally. Within 10 years, they will get cirrhosis. Some of them don't realize that they have MASL D because the MASL D can be asymptomatic, and they start drinking alcohol. If you see from the left to right, the quantity of alcohol weekly, 140 grams for females, 210 grams for the males. Starting from the left to the right, on the right, if there's drinking 350 grams females, 420 males in a week, alcohol becomes predominant and the metabolic dysfunction becomes less predominant. Now, there's a third bullet, which is alcohol-associated liver disease. It is purely due to the amount of alcohol they drink and the duration they drink. To give you just to make it easy to understand, one glass, if you drink four 12 cans of beer, 4 small shots of hard liquor, 4-5 ounces of wine, that is too much. That's what 350 grams and 420 grams. If you continue to drink, this is for the males. For the females, you have to 50. It's a half of the amount of alcohol if the females drink, they get into severe liver disease. So it is very important for you to understand, number one, whether do you have any metabolic liver condition? If so, how much you are drinking. So this is so essential for each individual, I don't want to call patient because I call them as individual. Each individual have to realize that what conditions they have, and they have to be very cognizant of the amount of alcohol they drink. Reason behind is currently at Hopkins, there are 2 major reasons we do liver transplant. One is called MASL D liver disease. Second is alcohol liver disease. We do almost 100 to 120 liver transplant. Then moving on to the right side is a specific etiology. There are certain medications can cause fatty liver. For instance, amiodarone, some tetracycline, methotrexate can do that. And there are certain other liver diseases such as Wilson's disease, a disease called a lysosomal acid lipase deficiency. It's very rare. It's an inborn error of metabolism. And viral disease like hepatitis C and hepatitis B, if they go untreated, long duration, it will cause cirrhosis, especially if you have genotype 3 in hepatitis C that can put out fat in the liver. And the 5th condition is called cryptogenic SLD, in which we don't know why these people get fatty liver. Now, this is the point I was making. Remember the MASL D, the first bullet I said, the first bucket. Now, how do you define steatotic liver disease? Number one, for instance, if you go and see a doctor, for some reason they do a sonogram. When the sonogram shows fat in the liver, you have to pay attention to that. Now, if your BMI, is more than 25 kilos, for Asians it is less, 23 kilos, or if your waist circumference in males 94 centimeter or females 80 centimeter, it is one of the 5 cardiometabolic criteria. So if you have steatosis on the sonogram or on the ultrasound, and if you have one of the 5 cardiometabolic criteria, you have to pay attention. That means you do have MASL D. So when a patient comes to that, you have to ask these 5 questions. What is your cholesterol level? What is your triglycerides? What is your blood pressure? If you have any one of those, if your serum glucose is more than 100 milligram per deciliter, you have to pay attention to that. If you have yes, if they don't know all of these things, if you only have fat on ultrasound, it's a very benign condition. I will explain to you at the end how to take care of them. Now, moving on to this is what happens, the natural sequence or natural history of the liver disease. As you see on the left side, it's normal liver. Then you get steatosis or MASL D. Now, on the bottom, you will see worldwide prevalence. 25% of the global population has steatotic liver disease. thanks to the so-called Western diet we are all indulging into. Now, it is not anymore Western diet. It's a global wrong food we have been eating. Number one. Number two, I always believe that, the so-called civilization, we are becoming more advanced. We are, sitting at the desk, not moving around, not doing exercise. That also adds up to the wrong food and the sedentary work. That's how we are seeing a lot of steatosis, which is 25%. But not everybody who has steatosis will get into steatohepatitis. Only 3 to 5% of the worldwide population will have steatohepatitis. But if you do the math, if there is 6.2 billion, 5% is humongous number. Then 1 to 2% of the whole population globally will get cirrhosis of liver. So this is the sequence of the event that goes on. Now, how do you define steatohepatitis? Steatohepatitis only by liver biopsy, but now we do have biomarkers I'll explain to you. When you do liver biopsy on this patient, if you see a lot of fat in the liver and you have inflammation, and more importantly, what we call ballooning. Ballooning means one liver cell, the fat gets accumulated in the liver cell, becomes like a balloon and breaks down. That means it's a cellular death. It gets so big and, it blows. Once you get that, we call it as MASH or steatohepatitis. Once you develop steatohepatitis, once you start developing scar tissue, that's a bad prognosis. Now, this again, the next point is the genes. There are 4 genes we have identified. It's called PNPLA3, TM6SF2, MBOAT7. This is what is important. What we have observed, so-called PNPLA3, it's more prevalent among Asians, in fact, among Indians, East Indians, among Hispanics. Hispanics has a very higher incidence of this PNPLA3 mutation. If you have, as you see on the left-hand side, if you have diabetes, if you have one of these mutations, your chances to develop steatotic liver disease or MASH is very high. If you have obese, if you have one of these mutation, your chances to develop steatotic liver disease is very high. If you don't have any of these mutation, if you don't have any risk factors, you will not get any steatotic liver disease, even if you have this tiny amount of mutation. Now, if you look among African American as a race, very low percentage of them have this mutation. Thank God, at least African American population is at least endowed with low mutation in PNPLA3 and TM6SF2. So this explains everything. There are 3 factors. One is genetic contributors, as I mentioned, PNPLA3, TM6SF2. The second is fat supply exceeding the adipose storage capacity in our human body. As you all know, fat is stored in the adipose cells, all over the human body. If that exceeds the amount of fat you need for your energy, it's going to cause MASLD. And this is contributed by the dietary and environmental contributors. And what are the environmental contributors? Number one, not doing any exercise, very sedentary lifestyle, number one. Number two, there is enough evidence currently we are accumulating the plastics, so-called the microplastics are going into the liver, causing liver damage, number one. Number two, there is also some studies showing people who live in most polluted area, they have higher incidence of fatty liver as those who live in the non-polluted area. So all these things, environmental factors are playing a role. Now, this is the basic pathogenesis. I'll explain to you. See on the top, you see the adipose tissue, that is the fat cells. What happens if you have a lot of fat in the cells? It becomes hypertrophied or it becomes big. Now, once this becomes big, insulin it becomes insulin resistance. In other words, insulin cannot have any function on these fat cells. Insulin plays a major role in breaking down this so-called fat. If we don't have insulin, the fat inside the adipose tissue, what we call it breaks down and forms free fatty acids. This free fatty acids goes to the liver. In the liver, it goes to the mitochondria. That is where it causes all the damage. Not only that, there are two kinds of cytokines your fat cells liberate. One is called inflammatory cytokines. The other one is called anti-inflammatory cytokines. Now, if you have a lot of fat, if you become insulin resistant, you make more inflammatory cytokines. These inflammatory cytokines for instance, if you have a lot of fat around the belly, they directly goes to the liver, causes an inflammation, causes the whole scar tissue. So this is the basic concept of what happens in the liver. How does the fat in the fat cells drive this inflammatory process? So now I think we all know about the GLP-1. It has hits all the newspapers, Wegovy, GLP stands for glucagon-like polypeptide 1 agonist, Now, what does it do? I don't want to go in details. Two important things you want to remember. One, in the brain, it decreases the appetite. Number two, in the stomach, it decreases the gastric emptying. By doing so, it decreases the food intake. You lose weight. That's the reason how you lose weight. And there's a good correlation of weight loss and the the content of the fat in the liver decreases. Thereby, it causes decrease in inflammation in the liver. What are the symptoms? This is a common theme. You all have to understand that almost 90% of the patients with fatty liver are totally asymptomatic. You don't feel anything. Some of the patients may complain they feel fatigue. Some of them do complain they have some right upper quadrant discomfort. Majority of the time don't have any symptom at all. So how do the doctors pick up? So when they go for annual checkup and they do blood tests, slowly they see their liver enzymes are abnormal. That is a clue. If you have an abnormal liver enzymes, you should not leave it alone. You want to figure out why the liver enzymes are abnormal. When the liver enzymes are abnormal, it indicates your liver is going through some element of inflammation, some ongoing injury. If you figure out early and if you take care of it, you can stop the whole downstream effect of fibrosis and cirrhosis. Now, second, when they do sonogram for abdominal pain or looking for gallstones, and they find out fat in the liver, that's how we get these patients, directed to us. Or incidental hepatomegaly. Patients don't have any symptoms. The other scenario, when the doctor puts you on statin, they are monitoring the liver enzymes. When the liver enzyme starts to go higher and higher, then doctor wakes up and the doctor sends the patient to us and they make the diagnosis of fatty liver. And as you all know, the medical insurance, occupational health checks, and annual review if you are type 2 diabetic patients. So the bottom line is majority of the patients are asymptomatic. So don't wait. Always have your physician check you up, go for annual physical examination, get them have blood examined. And if you feel fatigue or right upper quadrant discomfort, make sure they do some investigations. So this is a very important point. What does this point shows you? Now, I'll walk you through from left to right. There are two bars you have. On the left-hand side, it says risk of severe liver disease. What matters is the amount of fibrosis stage. There are 4 stages. Stage 0 means no scar tissue. Stage 1 and 2 is very minimal. Once you get stage 3 disease, your chances to get severe liver disease multiply by 14 times. If you get stage 4, it almost 100 times it multiplies. Stage 4 is cirrhosis. We don't want to reach that stage. We want to pick up the patients at the stage of F2 and F3, stage 2 and 3, and see we can totally convert it or stop the progression of the liver disease. If you look on the right-hand side, liver-related mortality. If you get stage 4 disease, 42.3 times you will die of liver disease than your other conditions. So the bottom line in this is the progression of the liver disease means you're going to die of liver disease. So you have to prevent from stage 2, stage 3 to getting into stage 4. That must be the goal of physicians. Now, this study has shown, can you regress if you have a lot of fibrosis? One of the study, in fact, it's called a Stellar 4 study. I was part of the study. When we did that study, when we looked into these patients, they had stage 4 disease. After we started them on treatment, when we followed them, those patients who had improvement, as shown in the dark blue bar, if they have improvement in fibrosis, the liver-related event, if they did not have any improvement, the liver-related event was 7%, as opposed to those, as in the red bar, it was only 1.1 time. In other words, if you have improvement fibrosis stage, you can diminish the liver-related event. So that is the bottom line. Now, just imagine if you're seeing a 40 patient, or if you're 40 people in the public, 10 of them will have, what we call fatty liver disease. Out of those 10, only half of them will have scar or advanced fibrosis, as you see on the right-hand side, the blue bar. Now, imagine to pick up that half, first you have to pick up these 10 patients or 10 persons in the public. You cannot do liver biopsy on all of them 10. So how do you find out? What are all the tools we have? So next 10 minutes, I'll go over with you those tools. Now, what are the strong predictors? Now, someone with an age above 50, pay attention, number 1. If you have type 2 diabetes, pay attention. Number 3, if you have your brother, sister, uncles, aunts, first-degree relatives had cirrhosis from steatotic liver disease, please get you examined, because you have higher chances to develop MASLD D and cirrhosis. We have clear-cut data now. This disease can be reversed. I'll share that with you. Now, what are the other risk factors? Sedentary lifestyle. Western diet, I wouldn't call it as a Western diet, because the Eastern people are also consuming this high fructose consumption. In other words, the wrong diet. I'll call it as a wrong diet. Overweight and obese, metabolic syndrome, more than 3 features, such as as I mentioned, diabetes, hypertension, hypercholesterolemia, or increase in BMI. As I already alluded to you, Hispanic ethnicity or Asian race. Asian race, they are not overweight, but they are still a higher incidence to develop this because they carry that PNPLA3 mutation. Dyslipidemia, PCOS. PCOS stands for polycystic ovarian syndrome, ovarian cyst. I think these people, as you all know, they have multiple cysts in the ovaries. Majority of they are amenorrheic. They don't have, they don't get children. And these are all the patients, gynecologists will identify them. If they have PCOS or if they have sleep apnea, they all have higher chances to develop MASLD. OSA stands for obstructive sleep apnea. Any of you who have sleep apnea, please, try to screen for fatty liver. Just to get a sonogram, get the liver enzymes. That's all you have to do. So now I think this is our guidelines. There are 3 guidelines. We have ASLD liver guideline. What does it say? If you have type 2 diabetes, suspect MASLD. If you have any metabolic risk factors, suspect MASLD. I think we already went over in the previous slide. Now, how do you diagnose them and how do you do the screening test? First of all, diagnosis, you have a high index of suspicion. Now, let me go over with you. The gold standard is liver biopsy. Imagine you cannot do those 10 patients liver biopsy. Number 1, liver biopsy, the limitations, very invasive, painful, expensive. It runs anywhere between $2,500 to $5,000. And 1 in 1,000 patient can get into trouble. Not only that, what we call sampling variability. Now, the fatty liver does not, distribute throughout liver in the same homogeneously, so heterogeneous. In other words, liver has got 8 segments. In each segment, the degree of scar tissue varies. So when you do liver biopsy, you are taking only one tiny sample. So that really does not give you the good sample. But that's what we have currently. This is what we have in our hand, the liver biopsy. And also, when the pathologist reads, there are not many hepatopathologists in the country, if not in the world, to really call the exact pathological diagnosis. And there should be an expert to do the biopsy. So liver biopsy is not the one currently we are to go to type of investigation. What do we have? The next step is blood test. This you all want to pay attention. I will focus on three blood tests. One is called a FIB4. The another one is called ELF. This is what I do. The simple test, FIB4, mast cell defibrosis score, and APRI. It's on the green bar. Of those three, FIB4 is the one anyone can do. What is FIB4? If you Google as FIB4, you will get in the Google, either in the smartphone or on your computer. It has age. You have to plug the age of the patient, AST level, ALT level, and platelet level. If you put it within few seconds, it will give you the number. What is the number? If you put the FIB4, if it is less than 1.25, that patient does not have advanced scar tissue. In fact, if it is less than 1, you don't even have to refer them to a liver specialist. Internist can or family practitioner can take care of the patient by talking to them about diet, exercise, and you can bring them back to your office once a year. Now, if the FIB4 goes above 1.3 or 2.5, that's the type of patient you want to send it to the hepatologist. Now, the second blood test is focused on enhanced liver fibrosis, ELF. So when the slide was made, it says not available in US. That's not true. I have been using it for the past 3 years. So what does ELF do? ELF looks into the 3 proteins. One is called hyaluronic acid. Second protein is called TIMP1. The third protein is called Pro3 collagen fibers. To put it in a simple word, it measures the proteins that is responsible to synthesize fibrous tissue and the enzymes that is responsible to break down the fibrous tissue. So they can calculate that in the blood and they can give the number and say, this patient does not have, does not have high ELF test. We can almost predict the prognosis. We can almost predict how bad the liver disease is. I will go over with you those numbers. The next imaging, there are 2 imagings currently we do. One is called a fibroscan. Other one is called MRE or magnetic resonance elastography. The new kid in the block is called corrected T1 or liver multiscan. That's not available in the mainstream yet. So I'll focus on transient elastography and MRE. The other terminology for transient elastography is fibroscan. I believe fibroscan is a stethoscope for a hepatologist. I have fibroscan in the next room. Every patient whom I suspect, I do fibroscan. Fibroscan is less expensive. It takes 5 to 10 minutes to do that. I will explain to you the next page. This is what the FIB4 score. Now, this is a smartphone. If you put FIB4, it will give you this column, and you plug those age, AST, ALT, and platelet count. It will calculate the FIB4 and give it to you the number. Now, I think we talked about the ELF study. Now, so they did do a study, like a 258. Most of this study came from UK. In UK, they have been doing it for the past 10 years. I always say it took 10 years, a decade, for it to move transatlantic. This was a study done here in US, 258 patients. They did the liver biopsy at the base. They measured the ELF score. What did they find? This is what they find. If at the baseline, if your ELF score is less than 9.76, as it's shown on the green line, it is less than 9.76, your chances to develop significant liver disease is very minimal over a period of 3.5 years. They followed them for 42 months. As opposed to the red line, if the ELF score is above 9.76, the chances to develop cirrhosis goes high. Now, if the ELF score is above 11.27, that means you have already developed cirrhosis. In the next 4 years, for you to develop liver-related clinical events, by that time in developing ascites, jaundice, cancer is quite high. So once you have ELF score above 11.27, that's a poor prognostic factor. So in my office, I do both FIB4 ELF score. Then I do transient elastography. This is what we call it. They call it as a vibration controlled transient elastography. What is that? It is nothing but sending the waves, like an ultrasound. Ultrasound has a different frequency. The transient elastography or fibroscan has a different frequency. So when you send the waves, the sound waves on the top of the liver through the right intercostal space, based upon how much the sound wave gets absorbed, how much sound waves gets, reflected, you can measure that reflection, and also you can calculate it logarithmically. Unfortunately, I don't have a wave to show you, but I'll explain to you. So based upon that level, one could say how much scar tissue you have. It takes only 5 minutes. The limitation is if they are obese, you cannot do. If they have abdominal ascites, you cannot do well. Operator experience, you should have at least 500 cases to get better on this technically, Now, if you do the fibroscan, there are 2 points we look into. One is called a CAP score that tells you how much fat you have in the liver. If it is less than 240, that means you're good, not much fat. If you have about 280, you have a lot of fat. So that number we look. Second number we look is called a kilopascal. As you see in this slide, fibrosis is unlikely if it is less than 7 kilopascal. So most of the patients who are less than 7 kilopascal, you can say you don't have advanced scar, you don't have any scar tissue. You can come back and see me an year or 2 years later. If it goes above 8.5 kilopascal, then you want to pay attention. That is the type of patient we would see as a hepatologist. Now, if it goes above 20 kilopascal, they are in bad trouble. That means they have portal hypertension. They probably have esophageal varices. In the next 6 months to 12 months, they will develop ascites, severe liver disease. So fibroscan helps you in measuring the quantity of all the fat and also the quantity of scar tissue. So far, we talked about liver biopsy, the blood test, and the third is the fibroscan. What about MRE? MRE is this shear wave elastography. I don't do that, so I'll skip that and I'll go to MRE. MRE stands for magnetic resonance elastography. It is very expensive. I don't do this in all my patients. Those patients who are very obese, number one. Number two, whom technically they cannot do the fibroscan, I send them for MRE. For instance, if I have 100 patients, I'm doing fibroscan, maybe 10 or 12 of them will eventually go on to have MRE. MRE is also not available everywhere, but in Baltimore, you can get it done in some units. Now, if in MRE, if it is more than 3.63 kilopascal, you have to pay attention. If it is less than 3.63, that means they don't have advanced fibrosis. If it is above 6, that means they have cirrhosis. So these are all the numbers that helps you to delineate how bad, how significant the liver disease in a given patient and also the prognosis of given patient. So I think we have these are all the common imaging, as I already mentioned, MR elastography, transient elastography. Now, this is how do you screen? This is a busy slide. Excuse me. But I'll take few minutes to explain to you. This is something which you all have to know. So a patient comes to your office. Patient has got obese patient or diabetes. So they have more than metabolic risk factors, 2 of them. Do a sonogram. They have an abnormal liver enzymes. What do? You always go over the history. Are they drinking a lot? And you do the other function tests, such as albumin and bilirubin. After you have done that, you do the calculation of FIB4. Anyone in the office can do FIB4. What all you need, age of the patient, platelet, AST, ALT, which every physician will do from CBC and CMP. When you have FIB4, say the FIB4 is less than 1.3, what you do is you tell the patient, hey, come back and see me next year. So you can stop the patient going on to the next stage. FIB4 is good between the age of 35 to 65. If they are less than 35, they have an autoimmune disease, then you may want to send that particular patient to the hepatologist. Now, what if it is FIB4 1.3 to 2.67 or above 2.67? If they have above 2.67, you know they have advanced fibrosis, they should come and see the hepatologist. If they are above 1.3 to 2.67, the next step is I will do the fibroscan. On fibroscan, if they are less than 8.8 kilopascal, I'll tell the patient, hey, listen, go back to your primary care. I'll give them some dietary, counseling about dietary modification and exercise, and I'll tell them go back to primary care. If the liver, the transient elastography shows 8 to 12 kilopascal, I will do ELF. Some patients I may do liver biopsy, and I may even start the treatment now, and I'll go over with you what current treatment we have. So this is the basic, anyone can screen. So for a primary care physicians, what all you have to do is know your patient FIB4, which you can calculate, and then send them to the next step to hepatologist or a gastroenterologist who is interested in liver disease. What treatment we have? Now, what is the holy grail? The holy grail of the MASH or the fatty liver disease is to reverse the hepatic fibrosis. Remember, I showed you stage 0, 1, 2, 3, and 4. You don't want your patient to be on 4. If there's enough evidence, fibrosis is a reversible condition. In the olden days, we used to think that's not true anymore. Even cirrhosis, up to a certain stage, it is reversible. If the cirrhosis goes beyond certain stage, it becomes matured and irreversible. That is then only patient will require transplant. Hopefully in future we'll come up with antifibrotics. People are working, throughout the globe, all over Europe, in US and in UK, they're all looking into antifibrotics. We have not reached that stage yet. So when you design study, we look our primary endpoint in any study, any medication, any drug, any methodology should prove there is a resolution of steatosis and inflammation without scar tissue advancing, number one. Number two, they should prove if they have stage 2 disease, it should go back to stage 1. If they have stage 3 disease, it should go back to stage 1. Now, if we start with diet and exercise. If you don't achieve the goal, then you go for the treatment. Currently, we do have only one treatment medication that is approved 2 months ago. I have the last slide. I'll go over with you on that. So what do? So in absence of this, again, this slide was made a few months ago. Currently, we do have one FDA-approved therapy. Before, what did we do? This is what we used to counsel our patient. Improve the overweight and obesity status by weight loss, exercise, and diet. That is on the top. What kind of exercise? So if you do more than 8,200 daily steps, these are all the, if you are obese, if you have sleep apnea, if you have acid reflux disease, doing these 8,200 daily steps will protect you, will get you some relief. If you are drinking alcohol, if you are smoking, if you are consuming too much of fructose, such as in all this, the carbonated sweet, sugary drinks, you have a lot of fructose. My patient who comes into my office, first thing I tell them, stop drinking all these sugary drinks. Drink only water, water, water. And coffee is good for you. 3 cups of brewed coffee. It really has to brew, not your instant coffee. And stay away from alcohol. Now, so this slide explains to you Start on the left side. Exercise alone reduces the liver fat. We have enough evidence for that. What exercise? Aerobic. Just do walking in the, beautiful, nice trail with a lot of gardens and trees. 150 to 250 minutes. I try to do that half an hour a day, at least 5 days a week. If you walk, you don't have just a brisk walking. You don't have to run. Or if you do a resistance training, 45 minutes a day, 3 days a week. This is the prescription I'm giving it to all my patients. Now on the right-hand side, diet. You see the coffee bean? It's like a liver. That means it's good for the liver, coffee beans. And what are the fructose sweetened beverage? As you marked as a, checked the X mark, you have to avoid them. All the buns, all the sweets, all the donuts, your fried food, you have to avoid them. Go on the green checkpoint, which is vegetables and fruits. My classic, breakfast, I always eat every day, fruits, maybe a couple of vegetables. That's my to-go breakfast. So this is number one, diet and exercise. Do we have enough evidence? Yes, this is the evidence. Look into this, the triangle. If you lose more than 3% of your body weight, I always tell my patient, I'll give them 6 months to 12 months. 35% of them will reverse the steatosis. In some study, 100%. If you lose more than 5% of body weight, you can improve the inflammation and the ballooning. If you lose more than 7% of current body weight, you can clear all the inflammation. If you lose more than 10%, you stop the progression of fibrosis. So there is enough evidence to show that. In other words, if you can achieve in your patient, they start losing weight, give them time, 6 months to 12 months. I always give them time, my patient. I don't tell them do it in 3 months. No, 6 to 12 months. If they have to lose 20 pounds, I tell them 24 months. So this is about the weight. Now, what is the healthy food? Now look into the top, healthy liver and fatty liver, saturated fat, cholesterol, food containing a lot of iron, such as red meat. Avoid red meat, avoid processed meat. Unhealthy cooking, grilling, too much frying. And what does it do? It produces amines called heterocyclic amines. What does it do? In the liver, it induces the insulin resistance. As I pointed out in the second slide, insulin resistance is the driving force for steatosis in the liver. So just, be cognizant of that. Stay away from red meat and processed meat. You can eat, fish. You can eat, once in a while, you can, have a steak, but be cognizant of this. See, again, what happens if you have highly processed food? See, so-called AGE. The AGE goes and locks into the cell membrane. And this cell membrane is the one that makes the fat to make an entry into the liver cell. Not only that, after the fat undergoes free fatty acids, it makes very low density lipoprotein and splits out into the bloodstream, which goes into the blood vessel walls, causes atherosclerosis and cardiovascular morbidity. In fact, patients with MASLD or the steatotic liver disease, high percentage of them will die of cardiometabolic disease more than liver disease. Now, this is the surgery. When would you send them for bariatric surgery or patients who want to lose weight? Look into that. Roux-en-Y and sleeve gastrectomy. If the studies have shown, this is actually came from both from Australia as well as from University of Indiana, single center. When they did the patient with morbid obese patient with obesity defined as BMI above 40, when they went through either Roux-en-Y or sleeve gastrectomy, 12 months later, 56% or 57% of them, the MASH, the steatoinflammation resolved without worsening fibrosis. And 37% of them had shown improvement in one-stage fibrosis. So what is the point? Point is, if you lose weight, you can reverse that. I always tell my patient, don't go for surgery if you can achieve through the diet and exercise. Because this surgery has a lot of side effects. I can go. Side effects are like malabsorption, micronutrient malabsorption. So you do run into trouble with the side effect after this surgery. Now, even the histologic improvement, there are some medications that was tried, vitamin E and pioglitazone. This was a study that was published in 2010. Do we recommend it? My answer is no, because this study was done in patients without diabetes, patients without much scar tissue. This study did not have any significant improvement in scar tissue. And also, we do have some side effect. This is a side effect. Vitamin E, when they were given 800 international units for more than a day for 2 years, there seems to be an increase in all-cause mortality risk, number one. Number two, there is also observed increased hemorrhagic stroke risk. Number three, there is also observation made prostate carcinoma risk. The risk is very low, but if you put them on vitamin E, younger patient is okay. If they are elderly, I would recommend not to. I'll tell you why. I mean, these are the point. And also, there is some medication that has come out now. What about pioglitazone? Pioglitazone we used to use it for diabetes. We still use it for diabetes. It is PPAR agonist. PPAR stands for peroxisome proliferator, accelerating receptor. What it does is it increases the glucose metabolism and decreases the fatty acid formation in the liver, and also it decreases the triglyceride formation. So this is what semaglutide does, which is Wegovy and the so-called GLP-1. You might have heard all over on the radio. People are taking this, the weight reduction magic medication. But what it does is, as I already pointed out before in the previous slides, it decreases the the appetite by hypothalamic inhibition through the neurons mediated through the glucagon-like peptide. But what it does is it also decreases the motility of the stomach. Patients can develop nauseous, and if they go for procedures like endoscopy or colonoscopy, they can get aspiration. You have to be cognizant of that. It's not for everyone. Now, this was a study that shown, this was published 3 years ago by Phil Newsom from UK. What he showed was giving semaglutide showed resolution of inflammation in the liver, as you see on the red bar, 59% of them compared to 17% on placebo. Resolution of inflammation and no worsening of liver fibrosis. But when they looked into, is there any improvement in fibrosis stage, it didn't play out much. So this is something, it is not approved yet. I think it's still undergoing phase 3 studies. So this is another GLP-1, liraglutide. What it showed is, on the study at the end of 3 months follow-up, fat accumulation in the liver was decreased when compared to placebo. And let me move on to this. This is SGLT inhibitor. This is used for patients with heart failure and also diabetic patient. What it showed is, again, by what MRI-PDFF, which is the magnetic resonance, one of the radiological studies to measure fat, it did show after you use this SGLT inhibitor, there's a decrease in fat accumulation in the liver. So what is the treatment plan? So if you see a patient with a low risk, before less than 1.3, your fibroscan shows less than 8 kilopascal, biopsy shows less than 0 to 1, just to modify lifestyle intervention, weight loss recommendation. They don't need any medication. That's all you have to do. And they move on to the indeterminate risk or into the high risk. This is where you want to send them to the hepatologist, So it's very easy. What do hepatologists do? This is the medication that really hit the market recently. It's the THR beta agonist. It's called resmetirom. It is the only drug that is approved for MASH. It got approved a couple of months. I started prescribing. Whom do you prescribe? Okay, now what does the study show? The study, we included the patient who had stage 2, stage 3 disease on biopsy. We put almost 250 patients, 80 milligram, 100 milligram. On the left-hand side, you see the MASH resolution without progression of fibrosis, 26% on 80 milligram, 100 milligram, 30%. The resolution. Now look on the right-hand side, fibrosis improvement, 26% on 100 milligram and 24% on 80 milligram showed improvement in stage 1 fibrosis. So based upon this phase 3 data, FDA approved this drug, but FDA gave a conditional approval stating that they want to see 4-year, at the end of 4-year, this what we see on histological improvement will translate into clinical improvement of patient getting better, living long without any liver disease-based events such as ascites, formation of cirrhosis. So we recommend resmetirom 100 milligram if they have 100 kilos, 80 milligram if they are less than 100 milligram. For 52 weeks now, and we will continue more. And this study is still ongoing. This study, based upon evidence at the end of 52 weeks, it got approved. And this is the final slide. These are all the medication that is currently ongoing, ongoing research. Semaglutide, lanifibranor, which is the PPAR agonist, both alpha, beta, and delta, and FGF19, FGF21. These are all looking promising. Even the GLP-1 agonist combination looking promising. In the next 2 to 3 years, we'll be coming with more medication with combination treatment, and we'll have a better opportunity to treat our patients with steatosis and fibrosis and give them a better life. And I will stop here and entertain any questions. Thank you all for listening. It's almost 8 o'clock. Okay.
Thank you so much. It is actually after 8. Whew, that was a lot. I learned a lot of new things. A lot of new things have happened with fatty liver. So if you take the slide down so I can get a better view as people ask. I know that there was a question in the chat box. I'm going to start with that. I have a lot of questions myself.
So that I think I'll say stop sharing, right?
Yes.
Stop sharing, right?
Yes.
Okay.
Okay. Fantastic. So I have a question. Haman, he actually joined us from London.
Hello there.
He says, thanks for the presentation. We could see it is a numbers game and knowing them, according to the presentation. He says his question is there some clear distinctions in conditions of African and Caribbeans with the liver? He noticed you had some clear distinctions with the Latin Americans and Asian community. So what about the Africans and the Caribbeans?
Very good question.
Yeah.
Very good question. I think now, number one, even the data that came from Africa, when we accumulate, even the incidence and prevalence rate, we could not get accurate. Reason is, unfortunately, even to do ultrasound, it is expensive for them, and they don't get ultrasound everywhere. That's number one, right? This is what I was told. Number two, now the study that I'm quoting came from Dallas. The Dallas, Florida, Texas. It is a heart-based study. They looked into 3,000 patients. So they stratified them based upon African Americans, Caucasians, and Hispanics. When they looked into that, only a very low percent of the African American had steatotic liver disease. Then they tried to figure out why so. Then when they looked into the mutant PNPLA3, only a very low percentage of them had PNPLA3. So I'll give you an example. Contrary to that, when we were taking care of hepatitis C, African Americans did not respond well to interferon. When we looked into the gene, they carried a gene called IL-28B TT gene. They become resistant to interferon. So genetics have some response. Why nature plays a role? There must be a good reason. Human our brain should try to figure that out, right? The evolution, the way the environmental trigger factors, the epigenetic factors all play a major role. Now, having said that, also the dietary habits, a lot of fibers. In Africa, people work very hard. What percentage of them they go on car every day, or, and they're sitting, on their hiney and working on that. As opposed to working hard, right? That matters also. What percentage of them, eat red meat every day, So that may play a role. But we are seeing a lot of them getting in, at least in the Western, eating the Western diet. I am seeing more African Americans getting MASH. But on the whole, if I have 100 patients with MASH and cirrhosis, very low percentage of them are African Americans. But alcohol, you should be very cognizant of that. I'm seeing more alcoholic cirrhotics. Hi, did I answer your question?
Haman. Yes, it says, thanks for, he said yes.
Okay.
He said, thanks for answering his question. Your answer was insightful. And he said, where can we keep a check with on ongoing research?
Okay. Well, now what is very exciting is African community has formed a liver unit, not liver unit, liver association. Just like we have 4 liver associations we have currently in the world. AASLD, EASL, Apostle, which is Asian Pacific, and ALA is Latin American. So African society has formed a good liver, and they are now combining with American Association, collecting all the data, coming up. We are teaching them how to collect all the data. They are getting better and better, improving, So it's just a matter of time. In the next year or so, we'll come with better data and publications, So.
And thank you so much. I have to, at this point, actually really call you out and thank you for always including us and for the heart you have for Africans. Because I know conversations we've had and all you have done, and how you are even willing to come back home with us to Nigeria to assist in hepatitis B, because it's a huge problem. Thank you. I wanted to seize this time to thank you. So, Auntie Tower, kindly unmute, ma'am. You have your hand raised. Thank you.
Good evening, everyone.
Good evening.
Thank you so much, Dr. Natarajan, for that wonderful presentation. Though there's a lot of medical terms that layman may not be able to dissect and really understand. But with the patient with sickle cell, they have a lot of bilirubin that is stored in their liver, and most of them end up with liver cirrhosis. Is it reversible?
I mean, unfortunately, no. I'll tell you why I'm saying this, because it's very heartbreaking for us. And we transplanted 2 patients' liver disease with a sickle cell disease. And both of them, they didn't even make it to 1 year, because what happens is after you put them the new liver, you still have not,
Sickle cell.
right, we're not clear the sickle cell. Until we come up with, yes, currently we do have gene study, with the CRISPR technology, we can slice the particular gene and, introduce the gene which is responsible for sickle cell formation. What happens to these patients? As soon as they get any stressful situation, they start sickling in the liver. When they start sickling in the liver, they get inflammation, cellular death. The cells don't get enough oxygen. When they die, they get inflammation and scar tissue. What we can do currently, we can prolong the fibrosis. We cannot, unfortunately, prevent cirrhosis nor reversal of cirrhosis. It's sad, but we have at least 3 or 4 patients every year we lose waiting for the transplant for sickle cell. And there is not a good protocol in the United States to do sickle cell disease. If you call all the transplant centers, reason is we know that eventual death, and people are not willing to take that risk, to do a transplant. But we have to come up with, at least Hopkins, they're trying to come up with certain protocol How do you oxygenate? How do you transfuse them during the transplant surgery itself? Keeping the oxygen flowing so that they don't die during the transplant.
Thank
My
you.
other
Thank you.
question, I have two questions. The other one is people that come up with liver cancer, is it possible for them to get liver cirrhosis because they have liver cancer?
Okay, I'll give you this. I'll give you the history, not the history, the line. You get cancer after you develop cirrhosis, number one. But maybe the reverse is true. You don't have to have cirrhosis to get cancer. Especially hepatitis B, and also with the steatotic fatty liver disease, we are seeing more of them.
Thank you very much.
And I think
Excellent
Benjamin
question.
has hands risen.
Thank you, man. Excellent question. Quick question before I call on Brother David Johnson. Dr. Veronica is in transit at the airport, and she had a question. She called, she zoomed in. She says, what is the impact of eating liver and kidney, etc.? Those meats, the liver, animal liver.
Those organs.
Organs. Thank you. That's the word.
Sure. I could answer that.
What is the impact to our liver?
The liver content, it has a very high in iron content. If you have a patient with hemochromatosis, iron storage disorder, we recommend them not to take liver. That is number one. There is no correlation between the liver inducing fatty liver.
What about the kidneys?
Kidney also.
Organs.
There is no. Right.
There is no correlation.
No correlation.
What about Shaki? Dr. Rakajan, what about Shaki?
What is it?
Shaki is still the organ?
Yes, organ.
What organ?
Is the towel? Is the towel part of the
It's
intestine?
called tripe.
Tripe.
Sorry, I didn't still understand.
It's called tripe. It's an organ meat.
Inside of the stomach.
Yeah, doctor. Oh, let him know that we eat a lot of
honeycomb
that in our
beef
food.
tripe.
Dr. V.
Honeycomb.
Thank you.
She's at the airport.
And we're boarding. Thank you.
Dr. Rakajan, it's part of the intestine. It's the towel where some of the waste is housed. And it tastes so delicious for Nigerians. So we're hoping that you will say it's okay.
No, I don't know the answer. So I don't want to give you a wrong answer.
Okay, I'll say this. I don't think there's a correlation. There is no correlation between eating liver, kidneys, and all those organ meats to the liver itself. There is none. Seriously. So I don't think there's a correlation. But
there is one correlation I have observed in Ghana population who eat that, I think they ferment that, they put it in the ground. There is what is that? Actually, it is like a root. It's a root, it's a lot of high carbohydrate. It ferments.
They put the roots in the ground. Is it cassava?
Cassava, right.
Cassava.
Cassava, exactly.
Okay.
Exactly.
Cassava is very different from organ meat.
Right.
Meat is from meats. Right. Cassava, yes, it's
high carbohydrate.
It's very high carbohydrate. So is there correlation between cassava and liver disease?
Well, there is so far no evidence that is published, but I have observed enough patients, I always tell my Ghana patients not to do that. And I have seen the enzymes coming down.
Okay. Fantastic. Thank you. So, Mr. David Johnson, kindly unmute.
Thank you. Thank you very much.
For coming on camera.
Yeah, I can see him. I see him.
Yes. Go ahead. Ask your question.
Oh, yeah. Great presentation, Doctor. I've learned so much through this presentation, 1 hour sprint there. So as I understand it, Doc, type 2 diabetes and age above 50 are strong predictors for fatty liver disease. So I'm wondering, in a primary care setting, would you recommend annual liver ultrasound for these patients? And I'm wondering as well, so that's one part of the question. And can you have cases where you have these patients who have normal LFTs, but can still have fatty liver disease? And therefore, I'm asking the question, would you recommend in terms of screening and managing these patients annual liver ultrasound for these patients?
Very good question. Excellent question. And especially if you have type 2 diabetes, and I would recommend to screen them. Type 2 diabetes. Now, today I saw a patient, 40-year-old guy, type 2 diabetes for 15 years, Caucasian male. He came with liver cancer. I think there's a higher chances to develop. So I would recommend them to screen them, even if you're normal enzymes. Because sometimes normal enzymes really do not, what is normal? That itself is whole, we can argue about it. Different races have different, level, but we cannot standardize them, and each individual, based upon your body weight, it can be. My recommendation, yes. Every year I would do sonogram of the liver on those patients. And you can do that FIB4 testing, Remember that platelet, AST, ALT, age. You can plug that, Did I answer your question?
Yes. You did. Thank you very much. I'm just looking to put my hands down. Thanks.
Yeah, excellent question. If somebody has diabetes, they should have ultrasound done, yearly. Actually, you won't believe this. One of my patients, after one of the talks you gave us, challenged me and said, you have not screened me. You have not sent me for ultrasound. So I quickly sent her for ultrasound and it was fine. Thank God. There's another question here that says, Sister Da Silva says, thanks for the presentation. Can fatty liver disease make it harder to lose weight?
Answer is no,
Okay,
no.
Fantastic. So I have some questions for you, since,
Dr. Benjamin.
Go ahead. You can ask your question. Kindly unmute. There you go.
Thank you so much. Thank you, Dr. Natarajan, for the presentation.
Dr. Natarajan is one of us financial experts from Bank of America.
Oh.
So you may want to hook up with him. Go ahead.
Dr. So you laid a lot of emphasis on the diet and the exercise remedies.
Correct.
I was wondering, have there been studies where rather than transplant, been an attempt to focus on protocol of diet, specifically channeled to reversing?
Answer yes. I'll tell you which. There's enough papers on that Mediterranean diet. Mm-hmm. Mediterranean diet is a diet that has been studied, number one. Number two, there is also what we call 5-2. 2 days of low fasting, intermittent fasting, 5 days of normal diet. So those two kind of diet has been shown to reverse the fibrosis, to reverse all the fatty liver. Answer is yes. Both the diet and exercise has been proven, with evidence of weight loss, you can reverse that. They would not. See, that's that's where we should put our money in, starting from school, from children. And I think the policy makers, yes, the whole New York State they went through. Remember the New York State school, they wanted to change the lunch, and don't want to mention the one party didn't want that. You know which party? Okay.
Diet, not the exercise.
Right.
Thank you so much. Thank you.
Sure.
Thank you. Thank you so much. You said those who live in polluted areas,
correct,
get into trouble with this. They can have fatty liver. What kind of pollution are we talking about?
I mean, we are talking about the, oil, gas, the fossil, that kind of pollution. I think so. I think as a nation, as a globally, as a humanity should start, planting trees and live in an environment where we are surrounded by greeneries, We lost it. We should get back. I was in Milan attending a liver meeting. I saw 2 buildings, 12 or 15 story, even 20 story. They have planted all over. You see trees, house in a trees. You can say house in a tree. That's the way it looked like, you know. They paid so much attention to that. Think about it. It's not only absorbing the sun rays at a different UV light, you know.
And they give us oxygen.
Exactly.
So yeah, I agree with that. So you also mentioned the GLP-1s, and I was hoping that you would say what you would say what they were, because people understand Ozempic and Mounjaro more. So the GLP-1s are
that's what it is, right?
that people are looking to get now in order to lose weight. And when people get on them, if you have fatty liver, it can actually resolve it, just because you lose that fat, you lose that weight. So just want a comment there. Then the coffee. You said 3 cups of coffee brewed daily is good, right?
Correct. There's a good correlation. I think you're talking about hundreds of thousands of people. They looked into that,
There's a research that came out not too long ago that suggested that drinking coffee, at least a cup a day, actually reduces the chances of certain cancers. So I tell my patients all the time, instead of smoking cigarette, to increase your focus, because that's one good thing out of many bad things that cigarette smoking does. You can drink coffee, because coffee would increase your focus also through the day.
I mean, in medical school, you know that in medical school, medical students lived on.
Medical students lived on coffee, except me. I didn't drink it. I didn't. I'm a tea drinker. I put my feet in water.
I see. Oh.
Overnight, I put cold water in a basin, and I put my feet in there. Really weird. But yeah, coffee is actually not a bad deal. It does a lot of good things. And I just wanted to mention that. Then one more thing I wanted to say, you met in the unhealthy cooking, you had grilled or broiled to well done level, as well as fried food are bad. Grilled or broiled food are bad.
No, okay, now maybe I should have emphasized to maximum, like almost blackening type.
Oh, if you grill or broil it to
blackening.
I see.
I mean, it's not good, Sometimes I have eaten salmon. They have cooked so much, it has blackened at the surface,
Yeah, blackened salmon. So, got you. Thank you. Dr. Izugu, kindly unmute and ask your question. Dr. Izugu, there you go.
Dr. Ravendhra, thank you so much.
How are you?
It's all good.
The Hopkins guys meeting on Medical Mondays with Dr. O.
I have seen him. I have seen his name.
We thank God again. Thanks for sharing your knowledge and all that. Was really very helpful. From cardiology perspective, can you just give us bullet points on statin therapy and liver disease and this, just general for us, please?
Sure. Number one, until 10, 15 years ago, statin and liver was bad, right? That's not true anymore. Number one, I would recommend everyone to, any statin is good for the heart. Number one, it's not as bad to the liver as they used to think. The point number two. Point number three, if you start them on statin, monitor their liver enzymes. Majority of the time, the liver enzyme goes high not due to the statin. It is due to the underlying fatty liver disease. Number four, once you start them on statin, if the enzymes are going up, put them in a pattern. In other words, monitor them, see the pattern, trend. If AST, ALT goes above 3 times of base level, that is the time you want to wake up. Or if the bilirubin goes twice upper limit of normal, you want to stop the statin. Because I have seen patients with a statin-induced autoimmune liver disease. I have transplanted 2 patients, statin-induced liver disease. But on the whole, millions of people are taking statin. It's more beneficial than risky. Let me put it that. And there is some evidence. Even for the portal hypertension, In the endothelial cells, it can decrease the fibrosis, It decreases the hypertrophy of endothelial cell in sinusoids in the liver. So
thank you so much.
Sure.
Thank you. Appreciate that.
In follow-up to that, I thought standard is if you start somebody on statin to treat cholesterol, you check the liver enzymes in 4 weeks. So to say top 6 weeks. If there's elevation, say 2 to 3 times, then you stop the statin.
3 times.
3 times.
3 times, right.
Then you stop the statin.
Suppose in 4 weeks it goes about 2 times, then repeat it again in another 4 weeks.
Okay.
You want to see the pattern, almost the trend.
Yes, and then you stop it. But if it's mild elevation, you repeat.
Don't worry, continue that. They will get better, in fact.
Exactly, you continue the medication. Usually when I start my patients, I check in 4 weeks. If it's fine, I don't ever check again. I just do the year. If it's fine.
Sometimes what we face sometimes is some patients, they really start on a very high dose of statin at the outset. And then, you run into this, and then all of a sudden they don't want to take, but really, anyway, go ahead and comment on dosage adjustment and all that, if you don't mind.
Sure. Yes. A very good point. So now there is a good data, even just pharmacologically, any medication, the dose is above 50 milligram, has a higher chances to develop drug-induced liver injury, dose dependent. So I always tell my patient, if they suppose if the enzyme goes up on 80 milligram of torvastatin, drop it to 40. On 40, drop it to 20. It's always better to go from below up, low up, 20. If you can't achieve, go to 40. Monitor the enzymes, The lower the dose, the better. So there's a good correlation between higher the dose, higher the chances of getting drug-induced liver injury.
Thank you. Thanks. Thank you so much. And Dr. Lola, kindly unmute. That's our pharmacist in the house. You asked a question about decaffeinated coffee. So I'll let you ask that question since you have.
Yeah.
Go ahead.
What's your take on decaffeinated coffee, brewed or instant? Benefits, advantages?
Sure. Now, I would not recommend any instant coffee, point number 1. Number 2, they did look into that decaffeinated and caffeinated coffee. Now, in the study, it did not make much difference, Now, but when you look into the component of the caffeine, correct? I prefer the caffeinated because that molecule is the one, it is an antioxidant. And what I always recommend, caffeinated coffee, maybe 5 to 8 ounces, 3 times. That is the recommendation I make, And brewed, not instant, because you want the water to sink through, to seepage through the coffee powder. That's how it gets that concoction, So.
Yeah, I always have a heart palpitation when I take coffee.
Right. Well, as you know, caffeine is the component in coffee, and also it is also seen in the tea also. They do have caffeine molecule in the tea in a lesser amount, So.
So what do I do with the palpitation, please?
Sorry?
Anytime I take coffee, I have palpitation, heart palpitation.
I see. I'm sorry. I mean, you are right. You are right. Some patients cannot, Now, even if you take, say, 2 to 3 ounces of coffee, you get palpitation?
Yes.
So it's unfortunate, you are someone, unfortunately, you cannot take coffee.
That's right.
Oh, Dr. Ezeudu.
You can use other antioxidants.
Look at all the doctors laughing on this platform. We can't help it.
Right.
Mr. Lola, because it means you cannot drink caffeinated coffee.
Let it go.
At all.
And cardiologists, let our cardiologists respond. Oh, yeah.
I would have taken that as I just said, leave the coffee alone.
Okay.
So fantastic. Sorry, but you can drink tea. Tea has caffeine in it, and it's to a lesser amount, but it also increases your focus, like green tea.
So the tea wise, you don't want to use the plastic paper used tea. The best tea is the tea powder brewing.
Oh.
If you go in the Chinese, they brew the tea. Yes. That's the tea you want to drink, not just taking the Lipton's tea and the plastic. Remember, the plastic still is not good for you,
No, but what about the tea bags?
Tea bag, that's what I'm talking about. Tea bags is the one. Bag is also,
Tea bag is not good.
It's not good?
No.
Yes. I always say the powder. The tea,
what's wrong with the tea bag?
Please. That's a paper,
Plastic.
It's not plastic.
No, it has some plastic. Honestly, it's been proved. And now I don't use tea bags, any kind of tea bags.
No, it has plastic. She is right, because if it is really paper, it will dissolve in all the... Wow. Right. It won't, permeate,
Wow.
Interesting.
Thank you so much. And, Sister Ola is our newest author on the platform. It's also the book 3 T's, and you can get that on Amazon. It's really a great read. So, question, Doctor. Another question. Is there any correlation between liver disease and kidney disease? Meaning, are you likely to get kidney disease if you have liver disease?
Sure. I mean, the answer is, when the liver disease gets really bad at the end, the kidney gets diseased. Not in the beginning, number one. Number two, there are some diseases common to liver and kidney, like polycystic liver disease. They also have cystic disease of the kidney that is genetically mediated. And if you have Wilson's disease, you can get Fanconi syndrome. So there are some combination of disease, but not kidney disease due to the liver disease at the end stage. When the kidney starts to fail due to the liver, you need both transplant,
Excellent question there. So, and thank you for the tea bag thing. That's new on me. Dr. Veronica is agreeing here. That is new education. Brother David said, this is a great presentation. How can we get credits? Great question. I need to figure out how we can start getting credits on Medical Mondays with Dr. O. Do you have any idea? And,
I mean, it's a long...
Go ahead.
It's a long drawn, because you have to attach with some of the universities or, some program, and they will go through who are all giving lecture, their CV, and, it's a long drawn process, to get a CM.
We'll have to do it. And Brother Johnson, if you know how, please help us get this, because this is educational every week. And we spend 1 hour, 2 hours, even if it's 1 credit hour we get every week. That's fantastic.
Dr. O, we'll talk about it afterwards. Then always can do it.
Oh, okay. Thank you. Thank you, Dr. Zugu. Uh-oh. I see something here that tea bag is okay, as it is not plastic, but made from plant fiber.
Oh, then, yes.
Is that correct?
Yeah. I mean, I don't know. I have not seen that. I'm sure people will be coming out with, new nuances,
If it's made from plant fiber, then that's good. But we need to investigate and make sure.
Right. Because that's, are they really selling the, is it factor?
Yeah.
Alternate factor.
Well, Auntie Mrs. Shogbeson, kindly unmute, ma, and ask your question. Auntie?
Yes.
Good evening, ma'am.
Good evening. The question is for the doctor.
Yes, please go ahead, ma'am.
As a patient, if I walk into your surgery and you find out that there's a problem, I have a fatty liver, why can't you start with my treatment instead of referring me back to my primary doctor?
Okay. So answer to that question is, it depends on how much scar you have, how bad is the liver disease. Now, if the liver disease is not that bad, it's a very initial stage, primary care doctor can take care of, the diet, exercise, can monitor that. Now, reason is we get patients from, say, 50 primary care physicians are sending patients to me. Our office is loaded with patients, so we try to take care of more sicker patients, So if your liver is not that sick enough, we'll send them back to the primary care. And now, the primary care would know when the liver gets sick, they would send back to the liver doctors. So we respect their, judgment.
Thank you.
Yeah, plus the primary care doctor, when they send patients back to us, we continue to monitor the patient. We understand it. See, when the specialist is a specialist, he will send a consult note to say that, okay, this patient's liver disease is stage 1. And I need you to monitor the patient with ultrasound every so often. So that is sent in the consult note to us, and that's what we will follow, we'll continue doing. If there's no worsening, then the patient is fine. If the liver then gets worsened, then we refer back to him, and he would then do the needful.
Okay, I guess it's almost 8:35.
Yes.
One more last question.
You've done very well, but you kept us till after 8 in your presentation too. So let me quickly, just read out some of these things to you. The fact remains, brewed tea. That's my sister in London. She zoomed in from London too. She said, the fact remains, brewed tea will always be better because it is more or less like herbs.
Correct.
So she agreed with you. Dr. Veronica said, she will send the form we use in education, CMEs for training. That's fantastic. And Clem said they can speak to the tea bag. Cotton, flax, linen are all plant fibers. That is why our parents use cotton cloth as sieves. Yeah, but we need to be sure what the tea bags are in. Now, Haman asked any comments on green tea, and I responded to that green tea is an excellent tea. What do you say? Any take on that?
I mean, there is not enough, data on that. People have really not dissected out between green tea and, my feeling is, my personal opinion, I don't have much data to give an expert opinion on that,
Yeah. Yeah, it's the packaging that we are talking about. So my sister asked the question, and I think this will be the last one we take for tonight. Says, so no preventative care till the liver gets worse. She's asking for prevention. Are there any ways to prevent fatty liver disease?
Basically? Oh, yes. That's very crucial. I think the whole talk today is the prevention. How do you prevention is diet and exercise, diet and exercise. Now, we should go back to where we all came from as a human beings, Homo sapiens. I always tell, even in my home, if you want to go to bathroom, try to go to the farthest bathroom. Try to climb stairs all the time. Try to walk as much as you can, If you are sitting and working on the desk, every couple of hours, get up and walk 5 to 10 minutes. Diet-wise, stay away from all this, rich food, red meat and all. And also, unfortunately, the food insecurity currently we see in this country. Poor people are the one who are suffering. Poor people are the one who cannot afford good food because this all the organic food and those food are becoming very expensive. So I would recommend, don't buy any processed food. Don't buy the food from the plastic bags. Try to get, fresh food and cook them. Spend time. In fact, I would rather spend 2 to 4 hours a week in my kitchen, cook my own dinner and put them away, for the whole week, as opposed to go out and eat in a place where I don't know how they are cooking. So these are all the preventive measures. we have learned, especially in the past 10, 15 years, we have learned all these things. So we should go back to that as a human beings, but unfortunately, the advancement has made us to pay the price also, It's a double-edged sword. Life itself is a double-edged sword. So prevention is better than cure. Prevention, yes, you can prevent fatty liver.
Fantastic. Thank you so much. And that was an excellent question. But believe it or not, I just got something from one of our Medical Mondays family, Dr. Oh, Ravendhra, you will not believe this. She just sent to the email tea bags and microplastics. So everybody stay tuned. Tonight, I'm going to forward this email to you from Sister Olamide. It's tea bags and microplastics. And this is from, NIH.
Correct.
Research from NIH. So this is authentic. That would tell us about the danger of microplastics in tea bags. So what
this is what I use for making my tea.
Yes.
It's from Israel. You put it there.
Take it out this way. Yeah. I have one like that. It's just that the tea bags were so easy, but we just learned something new tonight, and I'm going to send this out in the email. I think every one of us need to get what Auntie Tawa just showed us. Can you bring it forward a little bit so that people can see again? And brew our teas in there. But, knowledge is power. I'm going to send that email that was sent to me. I'll forward it to you. And see, for us to read and see prevention. We see lots of cancers, and we know that diet has a lot to do with these cancers, but sometimes we don't know why. You're eating everything, you're not eating meat, you're not eating that, but you're drinking tea with drinking plastic every day is, something that, we just learned now. So stay tuned tonight. I'll be forwarding those emails to you. There's another one, tea bags and plastics. So there'll be 2 of them coming to you tonight. Thank you so much, Sister Olamide Okikiolu. We appreciate it. Dr. Ravendhra, go ahead. I think
so. Can I just say, thank you, everyone, and it was my pleasure to have shared with you all, And I thank I thank Toyin for giving me this opportunity to share my knowledge with you all. Hopefully, I have given enough points. Even if I change one individual's life, I'll be so happy. Okay.
You've changed many. You've changed many. Let's start from the tea bags to the liver disease itself to fatty liver. It's a lot that you've done tonight. Thank you so much. We appreciate you. God bless you.
Thank you, everyone. Good night. Good night.
Thank you very much.
Thank you.
Thanks a lot.
Sure.
Thank you.
Thank you.